In this lecture, I am going to talk about adrenergic agonists. Adrenergic agonists are a large group of drugs that mimic the action of norepinephrine and epinephrine, which are naturally occurring in the body. Norepinephrine is also known as noradrenaline, and epinephrine is also known as adrenaline. Now, collectively, the agents that activate adrenergic receptors are called sympathomimetic, and the agents that block the activation of adrenergic receptors are called sympatholytic. So, now to get a better understanding of how these drugs work, let's take a closer look at neurotransmission process. There are 5 main steps involved in adrenergic neurotransmission. Number 1, amino acid tyrosine is transported into the neuron by the sodium-dependent tyrosine transporter. Once inside the neuron, tyrosine gets hydroxylated by the enzyme tyrosine hydroxylases to levodopa. Next, levodopa is converted to dopamine by the enzyme aromatic L-amino acid decarboxylase. The second step involves transport of dopamine into the synaptic vesicle, where the enzyme dopamine beta hydroxylase converts dopamine to norepinephrine. In the third step, arrival of the action potential triggers opening of the calcium ion channels and influx of calcium into the neuron. The increase in calcium causes the synaptic vesicles to fuse with the membrane and release its contents into the synapse. In the fourth step, norepinephrine binds to the postsynaptic receptors on effector organs, which triggers intracellular response, and norepinephrine also binds to presynaptic receptor, which results in decrease of norepinephrine release through negative feedback. In the fifth step and the final step, norepinephrine is removed from synaptic space by diffusing out into presynaptic membrane. Norepinephrine is also inactivated by the enzyme catecholomethyltransferase. Most of the quantity of norepinephrine get transported back into the neuron by norepinephrine transporter. Now, once inside the neuron, norepinephrine may be either transported back to the synaptic vesicles for future use, which basically means it gets recycled, or it can be broken down to inactive metabolites by the enzyme monoamine oxidase. Now let's talk about the adrenergic receptors. That is the receptors which can be activated by norepinephrine, epinephrine, and adrenergic drugs. Now the adrenergic neuron releases norepinephrine, while adrenal gland releases approximately 20% of the norepinephrine and about 80% epinephrine. At the end, norepinephrine and epinephrine bind to the receptors on effector organs, and these receptors are called alpha and beta receptors. Now let's talk about these receptors in more detail, and let's start with the alpha receptors. Alpha receptors can be divided into 2 main groups, that is alpha 1 and alpha 2. Now, alpha 1 receptor is a GQ protein coupled receptor, and as a rule of thumb, when alpha 1 is activated, it causes a stimulatory response mediated by increase in intracellular calcium. Now, alpha 1 receptors are mainly located on vascular smooth muscles throughout the whole body, and when activated they lead to vasoconstriction. They are also located on the dilator muscle of the iris, and when activated they lead to mydriasis, which is the dilation of the pupil. They are also located on urinary sphincters, and when activated they lead to contraction of sphincters, and that is why they cause urinary retention. Alpha 1 receptors are also located in liver, and when activated there they lead to glycogenolysis, which is breakdown of glycogen to glucose. So in summary, activation of alpha 1 receptors lead to sympathetic response. Just think about it, when you are in a fight or flight mode, it's advantageous to have constricted blood vessels in case you start bleeding. You also want to retain urine when you are fighting or running away, and you definitely need extra glucose. Now what about alpha 2 receptor? Alpha 2 receptors are GI protein coupled receptors. They are primarily located on presynaptic nerve endings, and when they are activated they cause decrease in production of intracellular cyclic AMP, which in turn lead to inhibition of further release of norepinephrine. Additionally, alpha 2 receptors can be found on pancreas, and when activated they lead to decrease in insulin secretion. Now let's move on to the beta receptors. Beta receptors can be divided into three groups, that is beta 1, beta 2 and beta 3. Unlike alpha receptors, beta receptors are coupled with the GS proteins. Now let's start with beta 1 receptors. Beta 1 receptors are mainly located on the heart, and when they are activated they lead to increase heart rate. They also increase cardiac contractility, and they also increase atrioventricular node conduction. Beta 1 receptors are also located on juxtaglomerular cells in the kidney, and when activated there they lead to increase renin release, which result in increase in blood pressure. Now let's move to beta 2 receptors. Beta 2 receptors are mainly located in the lungs and on the bronchial smooth muscles, and when they are activated they lead to bronchodilation. They are also located on the arteries of the skeletal muscles, and when they are activated they lead to relaxation of blood vessels, or in other words vasodilation. They are also located on smooth muscles in the gastrointestinal tract and uterus, and when they are activated there they lead to smooth muscle relaxation. The smooth muscle relaxation results in decreased GIT motility, and in the uterus it can cause inhibition of labor. Lastly, beta 2 receptors can be found in pancreas, and when they are activated there they lead to increase in insulin secretion. And now before we move on, let's talk about beta 3 receptors. Beta 3 receptors are mainly located in adipose tissues, and when they are activated there they lead to increase in lipolysis. Beta 3 receptors can also be found in the urinary bladder, and their activation there is thought to cause relaxation of bladder and prevention of urination. Now let's talk about the actual adrenergic agonists, the drugs. So adrenergic agonists fall into two major chemical classes, that is catecholamines and non-catecholamines. As a refresher, catecholamine is an organic compound that has a catechol, which is basically a benzene ring with two hydroxyl groups. On the other hand, non-catecholamines have a similar backbone structure, but without those two hydroxyl groups on adjacent carbons on benzene ring. Thus, they are named as non-catecholamines. Now, these structural differences create three main differences in properties between catecholamines and non-catecholamines. First, oral usability. Second, duration of action. And third one is CNS penetration. So, let's briefly talk about how they compare in terms of oral usability. Catecholamines are completely ineffective as they are quickly metabolized by COMT and MAO. These are the enzymes which metabolize these neurotransmitters in the gut, liver, CNS and even inside the neuron. Hydroxyl groups make the whole molecule polar, which results in poor penetration into the CNS. Now, on the other hand, we have non-catecholamines which lack the hydroxyl groups, and because of that, they are not a good substrate for COMT, and they are metabolized by monoamine oxidase very slowly. As a result, non-catecholamines can be given orally. They have a much longer duration of action, and because they are less polar, they also penetrate into the CNS fairly easy. Now, there are three types of adrenergic agonists. Number one, direct acting agonist. Number two, indirectly acting agonists. And number three, mixed action agonists. So now let's take a look at some examples, starting with the directly acting agonists. These agents produce their effects by binding to alpha or beta receptors and mimicking the action of epinephrine, norepinephrine and dopamine. These are naturally occurring in our bodies. If we talk about epinephrine, norepinephrine and dopamine, keep in mind that they are non-selective. It means they can act on both alpha and beta receptors. They are also catecholamines, which means that their main route of administration is by injection. Now, one of the most commonly used direct acting agonists in clinical practice is epinephrine. Epinephrine can activate almost all adrenergic receptors, and because of that, it is the treatment of choice for anaphylactic shock. Activation of alpha-1 receptors by epinephrine leads to vasoconstriction, which in turn decreases mucosal edema, relieving airway obstruction and increases blood pressure, relieving the shock. Activation of cardiac beta-1 receptors lead to increased cardiac output, which is why epinephrine are also used to restore cardiac function in patients experiencing cardiac arrest. Lastly, activation of beta-2 receptors in lungs lead to bronchodilation, which is why epinephrine is sometimes used for emergency treatment of respiratory conditions. Now, what about norepinephrine? Norepinephrine is actually very similar to epinephrine. However, therapeutic doses of norepinephrine mainly stimulates alpha-1 receptors, but no beta receptor activity. So it causes profound vasoconstriction and blood pressure. In comparison to epinephrine, the only useful indication for norepinephrine is hypotensive shock. Now let's talk about dopamine. So dopamine is somewhat special in that it is not only stimulate alpha and beta receptor but also dopamine receptor, and it stimulates them in a dose dependent manner. You can see here at low dose, that is at low therapeutic dose, dopamine acts on dopamine receptor only. Then as dose increases, it also activates cardiac beta 1, and finally at even higher doses it additionally activates alpha 1 receptors. So let's quickly discuss the most commonly used drugs in alpha 1 selective agonists. Best example of these is oxymetazoline and phenylephrine. Due to alpha 1 receptor stimulation, both of these agents can be found in products used for the treatment of nasal congestion and eye redness. Phenylephrine has the ability to raise systolic and diastolic blood pressure, so it is sometimes used in to treat hypotension. Now let's talk about alpha 2 selective drugs, and here we have a very popular medication called clonidine. As you may recall, stimulation of alpha 2 receptors leads to decrease in sympathetic tone, which may result in lowering of blood pressure, and this is why clonidine is commonly used for the treatment of hypertension. Now let's move on to the beta 1 selective agonists. Best example of this one is dobutamine, and again, as you may recall, beta 1 receptors are mainly found in cardiac tissues, so dobutamine increases cardiac rate and cardiac output, which is why it is used to treat acute heart failure. Next we have beta 2 selective agonists, which stimulate beta 2 receptors predominant in the lungs and leads to bronchodilation. These agents are classified by duration of action. So we have a short duration of action and long duration of action drugs. In case of short duration of action, beta 2 agonists such as albuterol and terbutaline, which are used for the relief of acute asthma symptom. And we also have long acting beta 2 agonists such as salmeterol and formoterol, which produce prolonged bronchodilation, and that's why they are used to prevent asthma attack. Finally, we have beta 3 selective agonists, namely mirabegron, which stimulates beta 3 receptors on the surface of detrusor muscle, leading to relief of symptoms of overactive bladder. So that it's for direct acting agonists. Now let's move on to indirect acting adrenergic agonist. Drugs in this group do not directly interact with the postsynaptic receptors. Instead, they enhance the effect of epinephrine or norepinephrine by either inhibition of the degradation or reuptake. Best example of these are cocaine and amphetamine, which work by blocking reuptake of norepinephrine, as well as dopamine, particularly in the region of brain that control the reward system, and this is why they are highly addictive. Additionally, these drugs stimulate alpha 1 and beta 1 receptors, which lead to sympathetic response such as rise in blood pressure and increase in heart rate. Lastly, I want to briefly discuss mixed action adrenergic agonists. The example of drugs that belong to this group is ephedrine and pseudoephedrine. These drugs can cause activation of adrenergic receptors by both direct binding as well as release of stored norepinephrine from presynaptic terminals. Ephedrine and pseudoephedrine have a long duration of action. Ephedrine and pseudoephedrine have a long duration of action because They are not catecholamines, and thus they are poor substrate for COMT and MAO enzymes which metabolize the catecholamines. Now, primary effect of ephedrine and pseudoephedrine are vasoconstriction and bronchodilation. However, due to its side effects and availability of better drugs, ephedrine is rarely used in clinical practice. Pseudoephedrine, on the other hand, also causes vasoconstriction and relaxation of bronchial smooth muscles. However, it mainly activates receptors located in the nasal passage. The constriction of blood vessels allow less fluid to leave and result in decreased inflammation of nasal passage as well as decreased mucus production. For this reason, pseudoephedrine is actually very commonly used as a decongestant. And with that, I want to thank you for watching.